It is my sincere pleasure and honor to introduce this year's John Conley Lecturer. Dr. Conley's contributions to our field are significant. He made extraordinary contributions to the scientific literature. He made many technical innovations, and his surgical experience coming out of World War II was truly extraordinary. He was the founding member and the first president of the American Society for Head and Neck Surgery. So I would like to, at this point, introduce our lecturer, who is Dr. Julie Freischlag. She is the William Stewart Halsted Professor and Chair of the Department of Surgery and Surgeon-in-Chief at the Johns Hopkins Hospital in Baltimore, Maryland. She is recognized nationally and internationally as an expert in the diagnosis and treatment of thoracic outlet syndrome, which curiously is something I personally have suffered from and am now fine. She is editor of the Archives of Surgery, which is one of the major surgical journals in our field. She also serves on several other editorial boards. She has published over 175 manuscripts, numerous abstracts, and book chapters. She's published important work on encouraging teamwork to decrease surgical complications, the top 10 list for a safe and effective sign-out. She's published on stress and burnout among surgeons, and the tipping point in the volume-outcome relationship for surgical procedures. I thought she would be an ideal keynote speaker for this conference, which is themed on bridging the quality gap in the care of the head and neck cancer patient. Her talk this morning will be on the topic of clinical and personal comparative effectiveness. Dr. Freischlag, thank you for joining us as keynote speaker. Thank you very much.
Great. Good morning. I'm a vascular surgeon. I'll disclaim that at the beginning, and we've never had a band at our meetings. This is just great to be preceded by a parade. When I was about 6 years old, I'm told, I don't remember doing this, a parade came through our small town, and my parents turned around, and I had marched away with them. So this brings back these memories of maybe that's what I really wanted to do. The energy in this room is incredible. To give this talk is amazing. I did not know Dr. Conley, but he certainly took your field to a different step, and really it's wonderful to be able to speak so that everyone can remember him and know what he did for your field as well as for surgery in general, looking at new techniques. It is sort of interesting. He thought that being a cardiologist would be stressful. I found that very funny as I read that, because certainly I went on to do these incredibly big operations that saved people's lives. So today I'm going to talk a little bit about vascular surgery. Our patients are very similar to yours. You know, they have similar age demographics. They all are cigarette smokers, or they lie to you about it, one of the two. They really come from the same generation, and I'm going to talk to you a little bit about aneurysms because that's some of my research, and look at the clinical comparative effectiveness that we are asked to do now. And I will tell you, surgeons have been doing that forever, and so we'll talk a little bit about that. And then I'm going to talk a bit about some personal comparative effectiveness data that is about burnout and stress and how to maintain your career for along the way. When I was standing in line yesterday at the airport, I did see a woman with a t-shirt that says half full, which we heard about today from the rabbi, about looking at how wonderful our careers are and how wonderful it is to take care of our patients. I have no disclosures. So starting off with comparative effectiveness, there's no standard definition for comparative effectiveness, but we have heard a lot about this, haven't we, in the last few years? And the IOM defines comparative effectiveness about the generation and synthesis of evidence that compares benefits and harms, and you're going to be doing that over the next few days here of alternative methods. And you have many methods to treat your patients, to prevent, diagnose, and treat and monitor a clinical condition and improve the delivery of care. Now, we know that this began first with the American Recovery and Reinvestment Act, and frankly, we all knew that was really about cutting costs, wasn't it? It really wasn't about care as much as decreasing cost. And then the Patient Protection Affordable Act in 2010, I think, really has established the PCORI to really look at research priorities and to oversee some of the outcomes we can do. One of our vascular surgeons, Bob Zolak, serves on this advisory panel, and that really is looking at recommendations for care, not just payment. Now, the definitions I'd like to talk a bit about today are effectiveness, to look at what is effectiveness. And this is really your real-world setting, that patient sitting in front of you and you coming up with a treatment plan that's the best you can do with what you know. And it's from intervention and real practice setting about what you can do. And we do have a lot of that in all of our practices. Where efficacy really is the outcomes from ideal circumstances, and I do a lot of clinical trials. We have an outcomes for clinical trials in my department, and this is ideal circumstances, and this is the best data, but we may not be able to have all this data as you sit and look at that patient. So I'm going to tell you a little bit about aneurysms and compare effectiveness and have a little thought about that efficacy, and then we'll talk a little bit about the personal at the end. So aneurysms are a big problem with death in the country, and if you look at it, it's a dilatation of an aorta, men to women. Most of them are in the aorta, but can have some other aneurysms more distally. And when you look at the risk factors, as I mentioned, cigarette smoking is the most important, hypertension. And then one thing I'd like to leave you with today is that the number one risk factor is genetic predisposition, and for me this became very personal. I was in clinic at the Johns Hopkins Clinic, and I got a call from my dad. At that time, my parents were living in Decatur, Illinois, which is a small town about 3 hours south of Chicago. My mother had had some chronic lower back pain and had been on Vioxx and actually had to been admitted to the ICU because of a Vioxx toxicity. And she was about my size, pretty easy to examine. And they were doing an MRI mainly to look at her back when they saw that she had a 6.7 centimeter abdominal aortic aneurysm, my mother. I was like, Dad, what's going on? He goes, well, they want to operate on her, and they think it's an urgent thing, maybe a contained rupture or something. And she was at St. Mary's Hospital. It was the hospital where I was born, so I had some affection for that hospital. And they did at least one aneurysm a year at that hospital. And the vascular surgeon down there, I sort of knew, and he could follow my dad's claudication, but that was about it, you know. And they both my parents are smokers. So I talked to my mom on the phone, and I said, do you really have more pain? No. So I put her in the car with my dad, got the IV out of her hand, and he drove really fast to Chicago. Stayed with my brother, and then was on Southwest Airlines to Hopkins. So you can get to Hopkins in about 8 hours, no matter where you are. And it turned out she did have an aneurysm, 6.7 centimeters, and short, fat neck, and she had to have an open repair by one of my partners, Dr. Perler. But I thought, how did my mother get an aneurysm? Because this is a male disease. But when we thought back, my grandfather, who was a coal miner in downstate Illinois, died while fishing in his boat when he was 67. He probably ruptured an aneurysm. And my uncle, my mom's brother, dropped dead at 58. And again, we thought that was probably heart, but probably ruptured an aneurysm. So I had a family history of aneurysms and didn't really know it till my mom presented with that. My aorta is 1.7 centimeters, just in case you're worried. Actually, Jim Black, one of my partners, was looking at my scan and said, why am I seeing your aorta from your subclavian to your iliacs to do that? So I don't have one, but there certainly is. So now you'll always remember, because of my mom, that there is a genetic predisposition to this disease, and aneurysms form between areas of hemodynamic factors, and that's why the aorta pinned down by the renals and the internals sort of vibrates and causes aneurysms. So most are asymptomatic. My mother's pain really was from her back. And most times now that people are getting CT scans for something else, as at my hospital and yours, I can't imagine getting admitted without a CT scan of your abdomen these days. Now, what's the risk? Risk of rupture is high as the aneurysm gets larger, as you can see, and this was published by Dr. Bernstein. So what do we know about aneurysms with effectiveness? What do we know out there? And we've done some studies at Hopkins about this. Robert McGee's a thoracic surgeon now that just took a job at the University of Colorado working for Rich Schulich, one of our people that just became chair there, and probably was a little busy the last couple days as he runs the surgical service in Aurora, and we hope all those patients do well. Rob is a thoracic surgeon, but did this work with Ben Brook, who's a vascular fellow at Dartmouth, along with Perler, who's is my division chief, and myself, looking at survival in ruptured aneurysms if you're a teaching hospital. So we use these national inpatient samples. I know a lot of you do that as well. We looked at ruptured aneurysms and looked at the hospital. What do they do at the hospital? Do they do open? Do they do endo? Are they teaching? And what was interesting with this study, you're able to see over 11,000 patients who were discharged with the diagnosis of a ruptured aneurysm. And one of the interesting things from this study was that 40% of patients chose not to have treatment. And if I were to tell you one thing that's really changed since I've been practicing now for almost 30 years, is patients are choosing not to have care, that they've decided that I don't want intervention. When I worked in Milwaukee years ago, we actually took care of lots of ruptured aneurysms, and over a third knew they had the aneurysm, but they had chosen not to fix it because it was high risk. But when it ruptured, they were ready, which is actually not the time to do it, as you know. But now patients are choosing perhaps not to have the care. And as you can see, it's a male disease, average age about 74. And of the open repairs, mortality was about 42%, which has not changed for the 30 years I've practiced. But if you look at whether it was a teaching hospital, they did better, and that's probably because the hospital's ready. We've got people in hospital, they take care of the patients, and if it's a vascular surgery training hospital, again, probably similar to your field, if you have someone skilled in head and neck cancer, they're going to get a better operation and a better assessment than in a place that's not. That there was actually a marked decrease in mortality. First time we've seen decreased mortality because of what we do. So of the endo repairs, as you can see, there was a markedly decreased mortality. So if you can treat the patient with a ruptured aneurysm with an endograft, which means anatomy, physiology, and all that, 19% death. And that was unbelievably a change in our practice now, that if you land at a vascular teaching hospital where they do endo and you're a candidate, your mortality is going to be markedly decreased. So other than factors to the patient, the hospital is important, and the teaching part was important. Now, when we looked at rupture rates of patients that refuse repair, we've done a lot of work in the VA system. Dr. Lederle's an epidemiologist I've worked with for over 20 years. We published this in JAMA, looking at what happens to those patients you decide not to treat. What happens to them? And what we wanted to say is we thought they were either too sick or the patient did not want care. What happens to their aneurysm? We went through this with my mom as far as deciding should we operate on her 6.7 centimeter aneurysm, and spent a couple months thinking about it before she underwent a repair. We looked at a couple hundred patients who had large aneurysms and watched them for a year and a half, and we were able to complete all assessment because it was the VA, and we also did autopsies, and about 45 patients did rupture. And if you look, these are the sizes. My mom was sitting there with a 20% rupture rate over the next year, and if it was 8 centimeters, you're going to rupture in 6 months. So if you do decide not to treat a large aneurysm, they will probably rupture unless they have some other disease that will take their life before. So rupture rate is substantial. If you have a large aneurysm, you decide not to operate, it will rupture, and once they rupture, the yield, even though better with endovascular repair, is not as good. The last thing we looked at to look at effectiveness is looking at rural hospitals, because one of our concerns is many of our patients, like my mom in Decatur, Illinois, show up into a hospital that really doesn't do aneurysm repair and may not do endovascular repair. Ruby Sue Mayberry is a resident in Georgetown and general surgery, and spent a year at Hopkins getting her MPH, and David Chang is a PhD who works with Outcomes Now in San Diego with Mark Talamini, did this study looking at rural hospitals. And again, wanted to know if you do see a patient in a rural hospital that comes ruptured, is it better to transfer them or is it better to take care of them, and do they live better if you transfer the patient? And she used this large database, over 67,000 patients, and looked at about 148 patients that were transferred and about 7,000 that ruptured. And what we found is that the age was about the same between rural and urban, a little bit older in the rural population, male sex a little bit less, more women in urbans, and as you can see, more diversity in the urban population for those that presented. Insurance status was interesting, that there were less uninsured patients in the rural setting compared to urban. And if you looked at who took care of these patients, a third were teaching hospitals in rural, almost 56% in urban. And if you looked at how many aneurysms we did, which we thought was important, fewer hospitals in the rural setting did more than 15 aneurysms. There did appear to be a lot of similar general practitioners in the 100,000 population, but actually there were more vascular surgeons per 100,000 in the rural. What we found is if you did present ruptured, you were more likely to be in a rural presentation, you were more likely to be transferred, but what's interesting, you weren't more likely to die, that the risk of dying in a rural hospital was just the same as in urban. And if you did do more aneurysm repair, as you can see, you had a better outcome. And the vascular surgeon presence actually improved your outcome, but not the general practitioner. So in our conclusion from this study, that rural hospitals did see more ruptured aneurysms, they're more likely to transfer, and that creates a delay. And that if you're not transferred and someone feels adequately prepared to treat you, you should go ahead and be treated in the rural setting. So let's talk about efficacy. So effectiveness is all these studies we have to help us look at our patient. Efficacy is the gold standard, and we've done 2 studies that really have looked at aneurysm. And this one is from New England Journal in 2002 that really gave us the size of 5.5 centimeters, because we wanted to know, what if we fixed this aneurysm earlier? Would the patient do better, and would they not face rupture? So we randomized these patients. I think patients that participate in clinical trials are the most unsung heroes of our world. The last thing I wanted to do was to let someone else tell me what to do with my mother's aneurysm. You know, I shopped her scan all over the country till someone finally told me, you know, Julie, no one really wants to take care of your mother. Just stay home with her scan. But I had it everywhere, just like you would. And these patients tell us, okay, randomize me. I'll either have early repair, late repair, whatever you say. And that's the true hero of a clinical trial. By the end of this trial, most all of these patients did have the correct treatment. About 2/3 that we watched went on to get repaired. I did this trial when I was in Milwaukee for 6 years. My best friend in medical school is Bruce Campbell, happens to be a head and neck surgeon who's here, and he actually was a faculty member there. And actually, I thank you for inviting me today, because I was able to catch up with Bruce last night. The primary endpoint was death from any cause from this, and we get a little confused sometimes with aneurysm repair, whether it should be to make it not grow or cause less death. And in this case, we're looking for less death. And we found that there was no improvement if you did it earlier than later. And that's why we feel that you get to be able to wait till the aneurysm get to be 5.5 centimeters. So some did rupture while we were surveilling them, but they were low. And once you operate on them, as you know, these people do have a little failure to thrive and come back in the hospital. But survival was not improved by elective repair, so that's where we get the number. This is great efficacy data. I'm sure you have it in your field as well, and we know that the size to utilize for patients for repair is 5.5. The last example I'll give you of efficacy is a trial we're involved in right now. I'm the national PI of an open versus endovascular repair trial. This is through the VA, so I actually go to Maryland. I go over to the VA twice a month and operate, as we're still coming up with follow-up in these patients. But this was our first paper that we published at 2 years from this group, and we published this in JAMA in November 2 years ago. This is another multi-center trial, our gold standard. We randomized patients to either endovascular, so they had to have the anatomy appropriate for an endograft with a longer neck, access through the iliac, and they had to have the physiology for an open repair. And then these patients, these heroes, let us randomize them to either open or endo repair. And then we looked for mortality outcomes. These were 99% male patients, 87% white, mean age was 70, and they were very large patients. Average weight was 90 kilograms, as you can see. Most were smokers, had coronary artery disease, and we did use all our different devices, which was an interesting way to do a trial with new technology, offering it along the way to patients in a trial. Very difficult to do, but we did decide whatever FDA-approved device was available, these patients should have. Now, the outcomes really showed that there was about the same number of deaths in both groups, but in the open repair, more died within 30 days, which was very interesting in our study, is that we used to say all aneurysm patients died of cardiovascular disease, either in the perioperative period or later, heart attack, stroke, or death. My mother actually, a year and a half after her aneurysm repair, had a stroke due to amyloid vasculitis and did die. And we had a lot of conversations in my family about whether or not her intervention for her aneurysm was worthwhile. Of course, my father thought it was okay. My younger brother, who's a teacher, thought it was okay. But my older brother, who's a venture capitalist, said, I thought you fixed her. You know, I thought that this was done to make it happen. My older brother really wasn't around much to help take care of her either, but that was another story in our family, which we all have. But looking at why they die, we thought it would be cardiovascular. And as you can see here, it's cancer. So it's things that you're going to see. It's either lung cancer, head and neck cancer, pancreas cancer. And we knew these patients did not have cancer when we initially operated on them. We do think that the effects of Lipitor, aspirin, and beta blockers in our patient cohort is making them survive once your aneurysm is treated to go on to get the other scourges of the risk factors they have. So this is the cumulative mortality, and as you can see, is over 2 years, the endovascular repair patients continue to have improved survival. We are just now reporting our 4-year data, where now it looks like the curves do cross at 4 years, but it does appear in our patient population, which maybe you are looking at as well with different interventions, that if you can do a less invasive operation, perhaps the patients will survive longer than a great big operation at the beginning, especially in those with risk factors of cardiovascular disease. So no ruptures were identified at 2 years. There were some endo leaks where the graft didn't seal with the endo, but very few compared to other trials. And the open group actually got a lot of hernias because they do have a collagen problem, and therefore we were the first to recognize that. This is a bar just showing which is better, where you can see that endovascular is better on your right side and open on the other. And for every age group, every comorbidities, every type of problem, you can see that really endo was better, except for one endograft, which sort of falls apart spontaneously later. Other than that all of the ones really look like endovascular repair, if possible, is better for our patients. And we already know, too, if you can have it when you rupture, that actually would be important too. So we really saw no difference at 2-year data, but we'll be presenting that it does actually cross at 4, that mortality was lower for endo, secondary procedures weren't that much increased, and the other morbidities were not that different. So we really did prove that endovascular repair, Efficacy, great clinical trial, is best for your patients if that's possible for them. The biggest issue, as you know, is cost. Endovascular grafts are about $35,000, and we're doing a cost comparison. And in the VA study, it looks like there's no difference in the VA system the way they cost account, but a regular open aneurysm graft is $500. So all technology, as you all know too, is expensive, and what would be the one reason to use it would be if the patients would live longer, and it looks like we were able to prove that. So for my last part of my talk, I would look a little bit about personal comparative effectiveness. And what is that? I think I might be the first one to coin this term, and I've thought a lot about comparative effectiveness along my surgical career. I chose surgery years ago as I came out of Rush Medical School because I really loved it. I was going to be a pediatrician, and then I did surgery to get it out of the way, and it was my thing, just like you found that your surgical career was what you wanted to do with your patients and your clinical skill. However, it is a busy life, and it is something that when you choose it, you need to choose wisely, as it is your profession and consumes so much part of what you do. All of us that have heroes, and two of them were introduced today in surgery, we have lots of heroes who have been our mentors and those that are there. And why do we love them so much? You know, because they love their career, they're passionate about their patients, and they have a life that looks like something we would like to live and learn. So as you look at your career, you want to enhance your career as you go along, but you also want to enhance your personal life. The one thing I think we sometimes forget, and I have to talk to residents about, is that your career is very, very long. It's not all in this one piece. And the new generation, I think, has really brought to light this work-life balance and trying to maintain some sort of personal life. The other thing that I am thankful for all the residents and students I get to spend time with, is keeping up that energy to apply new ways of doing things. Because as I'm sitting in my late 50s now, I'm 57, sometimes I just go, I don't want to hear one more new thing. You know, I want it the way it used to be because it was so safe and so wonderful. But they do keep you going and keep you energized to make that happen. I have a 17-year-old son that I went shopping with yesterday, as he's going to be a senior in high school. And it is funny to ask the same questions I would ask of you and see what answers you get. You know, he's someone that has kept me laughing a lot. Yesterday we went to a sports physical to do that, and the woman said she wasn't going to fill it out because it was Saturday and whatever. And I just looked at him. I said, well, I can fill it out. And he goes, God, I knew there was a reason that it's great to have a mom who's a doctor that has a different name than mine. And I'm like, yes. So the reason you want a mom with a different name who's a doctor is you can fill out that form so you don't have to come back to the pediatrician one more time. But there's other reasons I think that perhaps we can look at that, but he keeps me sane all the time. So I'm going to talk a little bit about some data from the American College of Surgeons. So I'm going to warn you, it's going to be a little depressing for a little bit, and don't get depressed. I'm going to give you the solution at the end, so you'll be there. But there are some issues out there as far as how we live our lives and what we do, and how we look at ourselves and not admit to us that we are burnt out or perhaps a little depressed or tired. So Lizzie Durba is an internist at Mayo Clinic who I've never met, but I've written now about 7 papers with her. That's the newest way, isn't it? Now your collaborators either by Skype or by email, and she's at Mayo Clinic and works with Tate, Shanna Felt, and Daniel Sattel. And Charles Balch is a surgical oncologist who's a specialist in melanoma who was at Hopkins for a bit and down at MD Anderson. Many of you know who he is and now is retired. And myself did this study through the American College of Surgeons, and some of you may actually have filled out the surveys, so we thank you. And we're doing another one right now looking at other issues with surgeons, and this one was all about gender. So we're going to start off a little bit about gender because I have a little interest in gender, as you can imagine. So we wanted to see if there was a difference in how people perceive their careers according to gender. In general surgery now, we just hit the tipping point for gender recruitment for general surgery. Last year, for the first time, 60% of our applicants were women, and that was the first time that our applicant pool looks like the medical school class for 20 years. As you know, the medical school class has been half women for many years, but this is the first time we had that applicant pool. And of the 1,000 people that applied for my program, 60% were women. The top 15, 11 were women, and 5 out of my 6 interns this year are women, and that's the first time we've seen this. And so we finally hit the tipping point of women wanting going into general surgery, and many reasons for that, but that's where we are, which is good because it's reflecting that. So as we look at this, we need to make sure that not only do they get into surgery and stay, or get into otolaryngology and stay and head and neck surgery, but then go on to have amazing professional lives. So how are we going to do that? So what we did is we gave these surveys and tools to people to see if you were burnt out, to see if you were depressed, and see, do you love your life? And that's what you all took for us, which was great. And when we did, we had a 32% response rate from the college, over 1,000 women. The second take-home point, besides that aneurysms are genetic, and you're always going to remember my mother, and she's smiling right now saying, yes, they will know about aneurysms because of me, is the second one, is women surgeons differed on every demographic variable measure. Now, I think this will change in another 10 years as women become more senior in our field, but for right now, your women partners are very different. So what did we see? The mean age of women surgeons was 10 years less than men. That's going to change in the next 10 years. This is probably going to be equal. More are single, about 2/3 are married compared to 90% of men, and about a few less are divorced than men. When you looked at and asked the question, does your partner and spouse work outside the home? Very big difference. 83% of women, their partner or spouse works outside the home, about half of men. And what do they do, we asked them. And for women surgeons, almost 1/3 of them were partnered or married to another surgeon. That's a real problem, okay, in the sense that those are two really busy people, aren't they? And I've got 5 couples in my department that are partnered or married to other surgeons, and I think we do this because we hang in the hospital so much, we just don't meet anybody else, right? So that's why you're going to see this more and more often. But the other thing is, if you look at the men, 5% of them are partnered or married to another surgeon, and 23% of the men are partnered or married to another physician. So our men also now have about 1/3 of physician partners or spouses. And as you can see, the women, it's almost half do. Some other healthcare professionals and a non-medical professional, 41% versus 25%. Now, do you have children was the other question, and more men have children. Now, 20 years ago, women surgeons, that number was 10 to 20%, so that's increased. And when do you have your kids? And I'm a great example. I had my son as a faculty member at age 40. I have 2 stepkids that are a little older, but my son was age 40, and I had to promise him I was going to live to 100 when he found out how old his mother was. So it's actually good that they're having children in residency now, but the men themselves have even more children in medical school as well. So what is the age of your youngest child? So women have younger children, and so you'll see that with the men having more than 1/3 greater than 22. Now, being the proud owner of 2 stepkids that are 31 and 32, they do recycle, and just because they're over 22, we all know they come back and they do have interesting problems. So you still are taking care of them, but a little bit different, and some actually are off the payroll and doing other things. So when you look at the practice, this is for you so you can look at what people told us about this. This is sort of looking at women and men and what they said they were doing. And the one thing to note is that the percentage of women in general surgery is about the same as men now, but less numbers overall. You can see neuro, orthopedics, surgical oncologists, transplant, trauma, but the percentages are much lower in some of the fields. So when asked how many years you're in practice, men much more than women. We work about the same hours, a number of hours in the OR, a little less for women, but number of calls were about the same. And when you ask them, did your commitment to your children slow your career down? Almost 60% of women say it did, where only 20% of men did. And when you ask them, who do you care for the child when they're sick or when there's a non-school day? And for those of us that raise kids where there's snow, you know, my son, when we moved to Baltimore and when he was off one day on a snow day, we came from LA, he goes, what's that? And then all of a sudden he fell in love with Baltimore because he loves snow days. But for those of us, you have to provide some care. You can see women did more care than they did. More spouses took care of that for men surgeons. Family member did, and women used nannies more often to make that happen. And when you ask the question, have you had a recent conflict with your partner or spouse's career, you can see the women a little bit more than the men. And when the conflict was with my career or their career, as you can see that most times it's their career when you're a man and my career when it's a woman. And were you burnt out? So the women were more burnt out. Now don't worry, this is going to get happy at the end, so don't be sad. There were more burnout with women and more depression because of these issues. And Lizzie tells me this is very different than other fields, and it's probably because we're so busy. You know, surgery, you can't turn it off. You can't say, I'm not going to the OR today. Urgent issues with head and neck cancer, urgent issues with vascular surgery. And that's why we love the field, isn't it, because of that. But because of that, you tend to have a lot of conflicts that occur at home because of the intensity. So they're more common among women surgeons, we need to know that. And they're similar, though, for men and women, and that we see that women have more of these conflicts. So we were very interested in this dual relationship because that does not exist in other fields. And so we wanted to see how surgeons in dual relationships differ from other ones. So surgeons whose partner was a physician, again, this is your new partners. These are your new faculty members. They're younger, they're newer to practice, they're more likely to delay having children, they're more likely to feel that childbearing slowed their career, and they're less likely to hear that they had enough time for personal and family life. And maybe we didn't have enough time either 30 years ago, but you didn't talk about it, right? You know, nobody talked. You just told them how miserable you were. Remember, that's how we walked around, how miserable, how busy, and that's how we sort of thought we could attract people to our field. You know, how silly of us. You know, that say, God, this is horrible. I'm here all the time, and you don't want to be a general surgeon? What's wrong with you? You know, so part of it was learning to really show people how much you love your career, and I think we need to listen to those with that. Surgeons in dual physician relationships did have this conflict with their partner and a work-home conflict than surgeons who was a non-working physician, like who's going to pick up the kid is sick, we've got issues at home, you know, the heat turned off, there's water in the basement, whatever those things you need to do, it happens much more often in dual physician relationships. Now, when you ask them, who is your domestic partner, and these columns are female surgeons and male surgeons. As we mentioned, about a fourth of women to physicians, a fourth of the ones married to physicians were female and 3/4 males. Working non-MD, much more in males than females. And stay at home, look at that number. Males had 96% of the stay at home domestic partners. Now, I've had all three of these kind of partners, and so I feel qualified to comment on this slide, and that I initially was married to a medical oncologist. I don't know why, but that's what I did, and that was interesting. And then I married Phil, because I actually married Phil in Milwaukee through a dating service that Bruce Campbell's wife made me sign up for. And I married Phil, who I'm still married to, and initially he was the CFO for a manufacturing company and was a working non-MD as we had our child, and that was okay. But since we moved to Baltimore 10 years ago, he went into retirement and stays home, and boy, do I like that. You know, so having a stay-at-home spouse is fabulous, because today, on Sunday, while I'm talking to you, he's taking care of everything that needs to be taken care of at home. And so there's differences in this, and I think part of it is recognizing those differences. So physicians married in part to another physician were more likely to have depressive symptoms and low mental quality of life. Now, just calm down. This will be okay. Then surgeons whose partners stayed at home, and that's really true. You know, I think that is, you're younger, you're trying to make this happen, and you need to be aware of when you do feel sad, depressed, overwhelmed, just can't take it anymore, that's okay. That we need to come up with strategies so you don't feel that way, and that many people are feeling that way, trying to balance it all. Because I'm going to tell you, I can't imagine a life without my two stepkids that are 31 and 32, and one's getting married this year, and my 17-year-old, and all the commotion I have in my life, because I really like my life. You know, I really can't imagine that not being there. However, it does get overwhelming, and I think we need to talk about it. So when you asked surgeons who are married to surgeons, that's the first column, and surgeons partnered with physicians, the set column, did raising children slow your career? And it looks like surgeons, we share the pain, okay? It's 50-50 that slowed it down. But if you're a surgeon-physician, it does appear that physician probably is taking the brunt of what goes on in the household if the surgeon's the other partner. So that we have to worry about those partners to other physicians, because the dermatologist or the rheumatologist is doing all the stuff at home so the surgeon can go to work. And that's what it looks like. And that could be our male surgeons, as you know. And when you ask the question, who cared for the children when ill, surgeons rarely do that, 15%. Significant other, about the same, as you can see. Family member, 12%. And when you care for the surgeon-physician, 30%, that other physician's doing it, and 11%. And if you're surgeon, you have a nanny, 40% of time, 37 physician. And the one question we really worried about is child home alone. Look at that, 13.9%. Who are those children? I hope they're old enough to be home alone, but that we tend maybe not to be prepared for these emergencies. So the last question about surgeons married to surgeons. If you're a surgeon, whose career was priority? And you can see it's pretty shared, 56 and 43. But it's a non-surgeon physician. There's no question the surgeon is taking priority of that physician. So we need to be sensitive of that. So surgeons whose partner is another physician have more challenges. Okay, there's more difficulty balancing that life than if your partner is staying at home or as a non-physician. So what do we do as leaders? Because all of you are leaders. You're leaders in your clinic, your division, your department, your lab. How do we deal with this? Because now it's here. It's up in front, personal. We don't not want to talk about it. We have to have strategies to facilitate the lives of dual career couples. And I think many of us are doing that, and we need to first talk about it to say we understand that this is a problem. How can we coordinate your schedule? You know, you both can't be in the OR at the same time if you're married to another surgeon. You both can't have first starts. You need to have adequate help at home, whether it's a nanny or daycare or a family member. You need to be prepared to make this happen. You need to have daycare if that's appropriate. When I was in Milwaukee, a great daycare across the street that my son spent time in and could go there at 11 weeks of age. You need to look at timelines for promotion, and we actually have done that at Hopkins, where we have looked at the fact that you could be an assistant professor for a little bit longer than 7 or 8 years, and that you can take your time for promotion and still be a valued member of the department. And whether or not you're the best or the biggest RVU producer or not doesn't probably make that big a difference as long as you're paid for adequate work. And we have a couple part-time people in my department, and we pay them appropriately for the work that they do. And we need to be accepting of that some people aren't going to be working exactly the same as far as number of cases, and making sure that they keep all balls in the air of education as well as research. And you need to really involve this spousal employment and ask what the spouse does and see what you can do. Because if you do get 2 people into your department that are married or partnered and they both are happy, they'll never leave, because they'll never be able to find a job that's best for both. I hired a woman colorectal surgeon when we really, really wanted her, and she came with a hepatobiliary surgeon. And he's fabulous. The other thing is not to assume that that partner is not any good. They actually might be the best one of the 2. And her husband has been fabulous, became associate program director, and is one of my best liver surgeons. And so having that partnership is very important. And they're very, very happy because they're both being able to grow their career and have had a child and have balanced that through that. But you do need to talk about it. And you do need to realize that they're different than we were, you know, that it's going to be different. And maybe they're right. You know, maybe it's better to pay attention and balance it along the way. Because obviously everyone in this room is incredibly successful, and you've made it through the ranks, and you've done your research and your clinical work, and you're amazing. But there were many people that we trained with back in the 80s that didn't make it, you know, that had big issues. And then we're not talking issues just being cut or not making it through the program, but it had issues in alcohol. And there were 2 that committed suicide when I was an intern at UCLA, and many things that had happened to all of us back there because we didn't talk about it. And we didn't think that that was important, that it was a sign of weakness to say, you know what, I'm really confused today. A couple examples I have back when I was a faculty member at San Diego initially. One of my partner's kid was in the ED getting her eardrum Lance for otitis media, and his wife was down there and needed him there, and I finished a case for him. He was doing a aortic bifem, and it was just the femoral anastomosis, no problem at all. And years later, I was doing a distal bypass in Milwaukee, and my kid developed 104 fever, and I had to get him out of that daycare that was so great, and my partner finished the operation. And the next day I told the patient, I had to leave because my kid was sick, and Dr. Cambria finished it, and the patient looked at me and she said, "How's your kid?" So I think there are these decisions you have to make as far as how you're going to take care of your family, and you use your partners and be a team, which we all have talked about now, which is much better for all sorts of things, but also for patient care. Your kids will grow up fine. As my kid told me yesterday, it's great having a mom with a different name when I need a sports physical done. That's one good thing he's told me. And he did tell me once when he was small, I picked him up from daycare, and he was, I think, 5, and he said, Mom, I'm just not getting enough care. And I'm like, what does that mean? And he goes, I'm not getting enough care. He goes, everybody else's mom's around, and they do this and they do that. You don't tend to show up for things, and I just think I need more care, and I went, all right, I'll try to figure out more care. Let's, can I go buy you something? That was usually my answer. Years later, when he was in high school, and these mothers are, these helicopter parents are hovering all over, he goes, God, Mom, I'm really glad you're not around. He goes, it's really great you're not there, because one, you tell everybody what to do, and I really feel pretty independent, so they will not turn into serial killers. They will do okay, and so part of it is trying to figure out, where you are and all that piece to do it. The best quote of my son ever was, when I moved to Hopkins, we were in the car driving around. I think he was 6, and he, as in all good conversations in cars, he said, Mom, can boys be surgeons too? Favorite line, I've published it, you can Google it, Freischlag, can boys be surgeons too? For a brief moment, I almost said no. How would he know? Okay, but instead, I said, Taylor, if you want to be a surgeon, with your mother's help, I can probably get you in to do that happen, because it is this old women's club, and we can probably make that happen. And how did he know that you were mainly guys? He had no idea, and so part of it is all what they see and all the energy to make it happen and staying real to yourself. And I do think as you go back, every time you talk to a faculty member, I ask about their spouse. I ask about their kids. I make them get physicals every year to make sure that they don't have issues, because we've had a few issues. It's legal. You can do that, okay? And so I want to know that they're taking care of themselves. I want to know what their issues are. And it really makes it so that they tell you, because they need to tell you, because otherwise you'll lose faculty and you'll lose expertise. So in conclusion, there's no standard definition for comparative effectiveness, personal or medical. You're going to have to figure out yourself, as well as that patient sitting right in front of you, what is the best treatment? What do I know with effectiveness? What do I know in clinical trials? Let me give you the best treatment according to your family, and what are you going to do according to your family? There's always going to be challenges and limitations. I wish I could tell you my career has just been perfect spot-free. When I moved to Milwaukee, I actually lived with Bruce Campbell and his wife and family for a few months, because that divorce was devastating to me. He saved my life those few months. I was a Campbell kid. It was great. He took care of me, regrouped, and then went on with my life. I'll never forget his family for doing that for me. You have friends and family out there that'll help you through those tough times. Population results are fascinating, aren't they, those 16,000 patients? But when you're looking right at my mother, what are you going to do with that patient, okay? You're going to take that information, but it's that patient and that family that you're going to take care of. And self-selection is going to affect what's done and when. You're going to figure out how to make that happen, what you're going to do with yourself, and keeping tabs of yourself is as important as keeping tabs of that patient that you're taking care of as well. You really need to make sure you review your own personal medical record as well. I give quotes to my residents every year when they graduate, and this is one of my favorite ones, knowing others is wisdom, but knowing yourself is enlightenment. And I think the best gift we can give to our trainees and our students and our families is to know yourself, your limitations, your strengths, your abilities, and the ability for you to stop for a minute and say, this is not going well, I need to regroup. Because even though you're in positions of power and leadership, you too will struggle with certain things that happen to you. And you too will have days that change overnight. I mean, we've seen that in the last week, haven't we? In Aurora, Colorado, in Syria. I mean, there's things happen all through the world that one day you're okay and the next day you're not. And so you really need to know what's going on around your world. This is a picture of our new hospital that just opened in April. It's heaven. It is just pure heaven. It's like an art institute on side. The only problem is the emergency room is way too big, and people are going through it and shopping like it's a mall, and we have 120 people there every night. Luckily, they're all medical, and so that it hasn't affected surgery much. I am delighted to be able to be chief of surgery and help run this hospital because it is heaven. I can't tell you how much it's meant for me to be here today. Carolyn is part of the ELAM group, which is women leaders. I was in the first year ELAM group. I recommend all the women in the world in the room to go into ELAM. Women can lead, men can lead. I think that we all need to work together as teams to go forward. And I can't tell you how much it meant for me to represent Hopkins. I think the entire otolaryngology head and neck department is here today. And when they put out the email that I was coming, I'm sure they were like, what? And I'm really pleased that they're all here doing amazing things. I led the search for the new head of otolaryngology and head and neck surgery at Hopkins, and we were pleased to choose David Isley, who was one of your past presidents. He's going to make us better. Wayne Koch actually was your president too, is an amazing faculty member at our institution as well. And so I can't tell you how proud I am of that department as well as to be here. Thank you very much. It's a girl's name too. I know, and I love it.
So I cannot thank Dr. Freischlag enough for being here and sharing her outstanding words of wisdom for all of us to ponder over and consider as we move forward. I noted one more similarity. There are several themes you're going to hear about in my presidential address tomorrow, but our sons share the same name. I have a son named Taylor, and so does she. So your son is 17, mine is 19. So thank you for serving as this year's John Conley Lecturer. Extraordinary talk. Thank you so very much. Thank you.